Hi everyone, very good afternoon, guys. I hope I'm audible and visible to all of you. And if yes, can I get a quick confirmation in the chat box if the AV is doing well, and then we can start without any delay. And till the time I get a confirmation, I think I can help everyone with the classes that are planned today and tomorrow. Today we are done with most of the classes. Right after this, we have one more class which is at 4 o'clock. This class will be conducted on the Unacademy app, and this is the continuation for the FMG free crash course that is going on. So, right after this session, we'll have a 15-minute break and we'll be meeting again at 4 o'clock. Also, an update about what are the classes planned for tomorrow. Tomorrow, Tuesday, we have three things planned. One is the morning 7:30 Kickstart morning session that is going to have the continuation of virology that we have. The next is going to be 11 a.m. We are meeting nowadays 5 questions we solve on Instagram every day at 11. So that is on point. And then tomorrow again at 4 o'clock, we will be having the FMG crash course. So that's the plan, guys, for tomorrow. And I hope you guys note it down. I'll also be posting all the links on Telegram and Facebook. You can pick them up from there. Also, an update about the AIMT that is coming up, the All India mock test, which is on May 1st, Sunday at morning 9 o'clock. And this is going to be free for everyone to attempt. Also, guys, this is particularly for the plus students. There is an FMG crash course that is starting day after tomorrow on the Unacademy app. This is for the subscribers in case the FMG students want to enroll for it. Okay, I've got a confirmation, which means we can begin right away. So we've got approximately 10 questions, a total mixed bag out of all the important targets that I had given to you. And this is the first question that you guys attempt. There's an adult female who recently got a unilateral salpingo-oophorectomy performed, which reveals the presence of nests of cells similar to the urinary bladder. This ovarian tumor can further show which other component? So, right, I've got two answers as I was pretty much expecting. So, most of you have gone in for the answer D, which unfortunately is incorrect, and I'll tell you why. See, if and many of you have given me the right answer also, which is B. I'll tell you why. So, if you read the question, yes, there's an adult female and she has an ovarian tumor which is similar to the bladder, and that is right. Whenever I have a urinary bladder kind of an epithelium, whenever I have a urinary bladder wala epithelium, means which epithelium am I talking about? Urinary bladder epithelium means transitional epithelium. I'm talking about the transitional epithelium. So, whenever this kind of an epithelium is found in the ovary, the tumor that we talk about is the Brenner's tumor. The tumor that we have is going to be the Brenner tumor. If only this much would have been asked, I would have also marked Brenner's tumor. But what did they ask you further? They asked you this ovarian tumor can further show which other component. So they are not asking you for the diagnosis. They want you to answer that along with Brenner's, what can otherwise also been seen. So remember, Brenner's in 25% of the cases can be associated with mucinous tumors also. That is a combo that is known in the ovary. And that is exactly what they had asked you. They asked you which other component can occur. So finally, your correct answer becomes mucinous cyst adenoma. I hope that question is clear. Yes, just in case most of you answered Brenner, so let me also show you how a Brenner tumor would be looking like in the exam. So I hope now the image is visible. Brenner's classical way of identifying Brenner's is you should look out for these kind of nests of cells. If they show you an ovary which is showing you these kind of nest of cells, start thinking of Brenner's. In the ovary, nesting should remind you of Brenner's. Anything else, so nests or islands, I've understood, but anything else, very good. The nuclei show you coffee bean appearance. The nuclei tend to show you coffee bean appearance. So yes, that is the entire point, which means I'm going to make all of you make a table. I'm not going to make much of it. You guys will be helping me with that table, and that table is all the coffee beans that we have that you need to know in pathology. So I hope first I'll tell you organ wise. Let's go organ wise. When I talk about the coffee bean, or when I talk about this coffee bean nucleus that we have over here, number one, if I ask you what in the let's start from here only. Let's start from ovary. What in the ovary? What in the ovary? So there are two tumors in the ovary that you have to know of. One was right in front of you, that was the Brenner's tumor, and the other one is the granulosa cell tumor. The granulosa cell tumor also shows you coffee bean nucleus. If I ask you the very, very famous thyroid, I don't think I need to ask you that, but in thyroid, it's papillary carcinoma thyroid, which you all have to know. And I'm sure all of you know that also. Now coming to the next, what else? Is there any bone tumor that you guys can help me with, which shows you coffee bean appearance? Any bone tumor, guys? It was a JIPMER exam question last year, so I hope all of you will be able to tell me. It is chondroblastoma. The bone tumor that can show a coffee bean appearance is referred to as chondroblastoma. And finally, what is the last one that we have? Langerhans cell histiocytosis. Langerhans cell histiocytosis, LCH. So these are all the coffee bean nuclei in pathology important, out of which in the ovary what is important? Brenner's and granulosa. How will you learn that these are the tumors of the ovary? So remember, whenever you talk about coffee, coffee always comes in a granular powder. Coffee always comes in a granular powder. So granulosa cell tumor, and if you want to have a good coffee with a good aroma and taste, you must always brew the coffee. So granular powder that has to be brewed. So granulosa cell tumor and Brenner's tumor are the ones that show you the famous coffee bean nuclei. Okay, having said that, let's move on to the next question in front of you. Let's attempt. There's a 29-year-old female who's detected with an ovarian cyst on ultrasound examination, and that is surgically removed. The cyst is uniloculated and shows the presence of clear watery fluid. The histological assessment that is shown is, I've got A and B as two answers, but majority of you is what I'll go with. Yes, majority of you have marked it as A, and I agree with you. So why was there a confusion between A and B? First and foremost, we always in the ovary have to do this differentiation of serous versus mucinous. Before I show you the photo, let us do the theoretical differences. So first and foremost, let's talk about the gross. If this is an ovary over here and this is an ovary over here, serous tumors, the cyst will have just one locule. Serous tumors tend to be uniloculated. That's the first important point. Whereas mucinous tumors will have multiple locules like this. Mucinous tumors tend to be multiloculated. Mucinous tumors tend to be multiloculated. So simple way of learning, mucinous will be multiloculated and serous will be single. Serous will be single. First point done. Second point, if it is a cyst, guys, my common sense tells me that whenever there is a cyst, there will be some kind of a fluid. So if I'm dealing with a cyst, and serous cyst is what I'm dealing with, serous refers to watery fluid, clear watery fluid. And when we talk about mucinous, mucinous means mucin, myxoid, jelly-like. Mucin will always be something like a gel, a little thick like a gel. So over here they had told me uniloculated, single cyst. They had told me watery fluid, so both the things were going in favor of serous cyst adenoma. Further, let's gross finding samajh aa gaya. I've understood how the cyst will look like. I've understood what kind of a fluid will the cyst have. Now let's talk about how will it look like under the microscope. Serous versus mucinous under the microscope. Before I get into this, one recall question. Which of them is capable of showing us samoma bodies? It's a general path question. I'm sure all of you know samoma bodies in serous or mucinous, and I expect everyone to know this. The serous ovarian tumors are famous for showing us samoma bodies. Perfect. Samoma bodies by the serous ovarian tumors. Perfect. Okay, now let's see the difference over here. Now first let me tell you the theory. If you look at serous tumors under the microscope, you will see a ciliated epithelium. So think, where in the female genital tract normally do I find ciliated epithelium? A normal ciliated epithelium, in which part of the female genital tract are you expecting? Fallopian tube, right? So can I say serous means that the epithelium will be very, very similar to a fallopian tube, and that is exactly what you can appreciate over here. You can see multiple cilia that are coming out. So remember, for serous it is ciliated epithelium. Whereas for mucinous, mucin will always look empty, khali lagega, right? So all the cells that you see over here, they are showing you some whitish areas. These cells are showing you whitish areas. They are clear. Why are they clear? Because they contain mucin. So simple. Now let's wrap up all our mnemonics. Serous has everything to do with S. With how many cysts? You'll say single cyst. Then it has clear watery fluid. Which kind of epithelium? Ciliated epithelium. Whereas mucinous will be multiloculated. What fluid will it contain? Mucin or gel. And which epithelium will it show you? It will show you clear epithelium because of mucin. I hope all these questions are sorted. We can move forward. Question number 3. So here we have one of the expected questions of this time. 23-year-old sexually active female presents with dyspareunia followed by vaginal bleeding showing a friable nodular mass in the vagina. The histopathology is shown, and which of the following is likely associated with the lesion? Very, very good. So quite a classical one, I suppose. And why have I got such an easy question? Because I want to teach you two questions and I want you to pick up the difference between those two pictures. So first I'll deal with this question. Yes, this is a case of DES. What does DES stand for? It stands for diethyl stilbestrol. Diethyl stilbestrol, that is DES. So first and foremost, DES is a drug which has been banned. It is no longer used. Once upon a time it used to be used in whom? It used to be used in pregnant women. In pregnant females, once upon a time, this preparation of estrogen used to be used so that they could, have proper uneventful vaginal delivery, and there was no problem in the pregnancy. So everything was going fine in the pregnant female, but it was realized that if this pregnant female gave birth to a girl child, if there was a daughter born, the daughter was landing up with this. And what is this picture showing me? Tell me your interpretation, guys. Do these cells have pink colored cytoplasm, or are these cells all khali? As you can see over here, all these cells are all clear cells, because I am talking about a clear cell carcinoma. I am talking about a clear cell carcinoma. So yes, I have known that DES is a drug. If it is given to pregnant females, the daughters can be born with clear cell carcinoma, and that is very famous in any part of the female genital tract. Like over here, patient का vaginal mass था, but it could be the cervix, it could be the uterus, it could be the ovary, basically some part of the female genital tract. That is why, what do we call them? These kind of histories are referred to as the DES daughters. These kind of histories are referred to as DES daughters. DES given to mother, and the daughter lands up having clear cell carcinoma. Now the problem is that there's a very similar looking photo in pathology that we have, that happens to be this. First, please give me the answer and then we'll see the difference between the two pictures. 29-year-old woman is evaluated for an abnormal pap smear and that shows condyloma acuminatum. Biopsy is given to you. PCR will demonstrate which of the following infectious agents. Very good. Excellent. We are talking about D, that is human papilloma virus. Firstly, they've told me everything about it. They've said patient has condyloma acuminatum. What is condyloma acuminatum in simple layman terminology? Layman terminology, it's nothing but a wart. So there's a female who has a wart, and when they did PCR, obviously for warts or for condyloma acuminatum, I expect human papilloma virus. First, let's talk about the theory part of it. Human papilloma virus is of two types. One is the low risk human papilloma virus and one is the high risk human papilloma virus. Low risk wala kya hai? It is HPV 6 and 11, chota numbers. High risk wala bada numbers, 16 and 18. So over here they've said what? What is obviously a benign condition. Condyloma acuminatum is a benign condition. So the low risk ones are responsible for formation of the warts. Basically 6 and 11 HPV are the low risk ones for wart. Very good. Now what is this picture shown to me? Anyone who wants to attempt, what are these cells known as? Let's pick up this cell over here. These cells are known as coilocytes. That's the classical cell that we have with human papilloma virus. How do we define a coilocyte? There are two descriptions. First, tell me the descriptions and then we'll see it. Look at the nucleus, guys. Nucleus is not a regular nucleus, it's a dark nucleus. Let me draw it. If this is the cell, the nucleus is a dark one looking like this. Exactly how a raisin, everyone's seen a raisin. I'm sure you've eaten a raisin. It's nothing but kishmish. Raisin is nothing but kishmish, and it looks very shriveled like this. So that is how they are defining it. They are defining it as a raisinoid nucleus. Raisinoid nucleus. And if you see the area around the nucleus, it's empty. So we call it perinuclear halo. We call it perinuclear halo. So now you'll say that, ma'am, in the previous photo also everything was khali khali, everything was clear. Over here also I'm seeing that halo, everything is looking clear. So what do you pick up for your difference? For your difference, you pick up the raisinoid nucleus. See, in this clear cell carcinoma, did you see a regular round nucleus? Regular round circle nucleus over here, nothing raisinoid, nothing fancy. Whereas in a coilocyte, you're seeing that kishmish type of raisinoid nucleus. I hope the difference is clear because this can very commonly be a source of confusion in the exam. Okay, all said. This is a question that I had put up on Instagram also day before yesterday. So just as a very quick recap, only 10 seconds and I'm going to move forward. Not planning to spend much time. A very quick recap. Reinke's crystalloids are seen in perfect Leydig cell tumors. Do normal Leydig cells show you Reinke's crystalloids or only tumors? Do normal Leydig cells also show you these crystals or do only Leydig cell tumors? Okay, you say, ma'am, both. Perfect. Please remember, a normal Leydig cell will also show you these, and obviously the tumor arising from it will also show you the Reinke's crystalloids. Simple one-liner, nothing more that I have to teach you in this. Let's move on to the next one. Here we have a 30-year-old female who presents with abdominal pain. Ultrasound shows an abdominal mass. Gross shows grey-white solid tumor with focal yellow areas. Microscopy shows spindle cells with vacuolated cells. Two things are there. Two things are there everywhere. So let me try and analyze what exactly are they, trying to point out over here. So let me see when I look at the gross. Let me look at the gross picture. All of you got a right answer. I've seen white areas also, number one, and I've seen few yellow areas also. Perfect. Now let me look at the microscopy. On microscopic examination, I've seen some spindle cells also, and I have seen some vacuolated cells also. So now I need to correlate everything and come to an answer. And yes, your answer is fibrothecoma. This is the fibro part. It's a combination of fibroma as well as thecoma, and that is why together they are referred to as fibrothecoma. Firstly, fibro, whenever I say fibrous tissue, it will always be white in color and it will always be spindle cells. White in color, spindle cells. Can anyone tell me the IHC marker now? That is not written in the question. For fibroma, what is the IHC marker? Very famous for any fibrous kind of a tissue, any fibrous tissue anywhere in the body, any spindle cells, the marker will always be vimentin. Very good. The IHC marker for fibroma is vimentin. So fibroma is done. The white color tumor showing me spindle cells was fibroma. Now let's come to thecoma. Thecoma was yellow color. Why was it yellow color? Yellow color because it contains fat. That is why you were seeing vacuolated cells. You were basically seeing cells containing fat. And if I have to stain fat, then what is the special stain that we are going to use over here? I'm not going to ask you that because all of you know by now. Oil red O. The very famous stain for fat is going to be oil red O. So finally, can I say fibrothecoma will be a tumor which will be vimentin positive also and which will be oil red O positive also. Fine. Having said that, wrap up to this question, I hope. And let's move on to the next one. A very important one, I suppose. Alpha-fetoprotein. Alpha-fetoprotein is elevated in all except HCC, hepatoblastoma, amoebic liver abscess, or embryonic carcinoma. Okay, some answers Well, most of you are right. Perfect. So we have to make a table. Alpha fetoprotein, definitely one of the most important tumor markers that we are expecting. So alpha fetoprotein, number one, if you talk only about the ovary, then which is the tumor, which is not written over here, it's not embryonic carcinoma. The ovarian tumor in which this can rise most commonly is yolk sac tumor. Yolk sac tumor is what is important. Now when we talk about the liver, for the rest of it, first we'll talk about the infections. Which infection can result in increase in alpha fetoprotein? Amoebic liver abscess. Amoebic liver abscess, which was given to you in the options. And next, if I ask you what are the tumors that can lead to elevation, one of them is hepatocellular carcinoma, and the other one is going to be hepatoblastoma. So these are two things, two tumors of the liver, HCC and hepatoblastoma. One infective etiology, amoebic liver abscess, and in the ovary it's the yolk sac tumor, not embryonal carcinoma or embryonic carcinoma. Because can you tell me that when embryonic carcinoma occurs in the ovary, there is a very famous CD marker for which it is positive? I'm sure all of you know this. Which CD marker? Help me with this question, please. CD 30 positive. Wow. If you remember, CD markers means you're on a very good track of your revision. Embryonal carcinoma or embryonic carcinoma is CD30 positive. One more question out of this slide. What is the kind of appearance that a amoebic liver abscess gives us? There's a kind of a liquidy appearance which is very, very famous, which they will obviously ask you in the paper, the anchovy sauce appearance. Whenever they want to guide you towards an amoebic liver abscess, anchovy sauce appearance is something that will always be mentioned. Okay, so if alpha fetoprotein except embryonic carcinoma, let's move on to the next one that we have, which is this. Which of the following is true about glomerular diseases depicted? I think the image is on a separate slide. Try attempting without the image first, then I'll show you the image. It's gotten switched on to the other slide. So first please have a look at the picture well, or the question well, before I show you the photo. Pick up all of these. You know the disease that we are talking about by now, by the options. Yes, exactly what I said, Dr. Prativa. I can show you the picture, but the picture is this. Okay, the picture is this. The picture has gone on to the other slide. That is why I was not wanting. So everyone's seen the picture first. Now I'll get you back to the diagram, the image. Done? Now I get you back to the question. Yes, guys, let me know. Most of you answer B and D. Acha, so first and foremost, okay, let's reassess. Pehle, let me just show you this particular photo over here. If I show you this picture, what did all of you think of? Something was written also quite characteristic. Immunofluorescence was shown. So let's reattempt. If I'm seeing immunofluorescence, what pattern? Just tell me the pattern. Bas itna batao. Then we'll see the question later on. Pattern is linear, written in front of you. Linear means the same green color everywhere. The same green color everywhere. Actually, there were two photos. That is why वो उस वाली slide पे fit नहीं हो रहा था. So this is photo number one. Photo number one is showing me a linear pattern. Green color, same green color everywhere. Photo number two for the image question was this. What kind of an immunofluorescence pattern is this? And now you see the difference. First is analysis, then we'll go to the question. Over here you will say that the green color is very sharp. Then over here you will say the green color is very dull. Over here you will say the green color is very sharp. Then you will say, ma'am, again over here it's become a little dull. So basically we are talking about a granular pattern, which is very famously known as the starry sky pattern. So what are the two pictures? Number one picture, see the same green color everywhere, no shining dull, nothing. The same green color everywhere, the same green color everywhere. This is what? The linear pattern. Over here shining dull. So that's the granular or the starry sky pattern. So what disease? Everyone's told me, ma'am, we are talking about RPGN. All in all, these pictures are showing me RPGN. Now you've understood the glomerular disease. Now let's start analyzing whatever is written over here. So first and foremost, you had to find out the true statement. Let's see. The first statement reads, let's focus on this. Immune complex mediated crescentic glomerulonephritis type 2 is associated with a linear staining. Is that so? Is type 2 RPGN associated with linear staining? No. Type 1 RPGN is associated with linear staining. So this becomes a wrong option. Let's move on to the second one. Anti-glomerular basement membrane, which is type 1 RPGN, is that associated with granular? Again, galat. Type 1 is associated with linear. So this is also a wrong statement. Third one. In posse immune complex type, which is type 3 RPGN, deposits are commonly present. No, the reason why I call it posse immune is कि उसमें कोई deposit नहीं है. Posse immune means less of immunity. The concept only says that I'm not going to have deposits in it. So deposits are commonly present, nahi, deposits are rarely present. So which is the only correct statement, the only true statement, that out of all of these, posse immune type 3 is the most common type of RPGN. So let's do a very quick recap. What say, guys? Let's do a very quick recap of the three type of RPGNs that we have. So these are the three types that are written in front of you. Number one, I hope everyone can see that. Yes. Okay, so we have type for सबसे पहले RPGN. When I say RPGN, there's another name in pathology that is given to it. What's the other name? Crescentic glomerulonephritis. Actually, from a pathology question, this is what is going to come to you. It is going to be crescentic glomerulonephritis. So my first, whether I'm talking about RPGN 1 or 2 or 3, crescent will be seen. So why not quickly see a picture of a crescent? Let's have a look at a picture of a crescent over here. So have a look at this glomerulus. If I say this is the glomerulus, you'll say, ma'am, there is someone sitting on top of the glomerulus like a cap. This cap is a crescent. Similarly, if I say this is a glomerulus, then you'll say someone is sitting on top of the glomerulus like a cap. So this cap or this flap, this thing is nothing but a crescent. Yes? Why am I calling it a flap? This half moon kind of structure, I'm calling it a flap because that helps me with the mnemonic also. What is a crescent made up of? Primarily, I'm telling you, primarily it is made up of F for fibrin, L for leukocytes, and P for parietal cells. Repeating, it is made up of F for fibrin, L for leukocytes, and P for parietal epithelial cells. But what does the update tell you, guys? This is primarily, but rarely can it also be made up of the visceral epithelial cells. Rarely can it be made up of visceral epithelial cells. Yes. So predominantly, if someone asks you, it is fibrin, leukocytes, and parietal epithelial cells, flap. Rarely visceral epithelial cells can also be seen. So that is what a crescent is made up of. So now you'll ask me that, ma'am, if I look at this crescent under an electron microscope, if I look at RPGN, or that crescent under a electron microscope, black and white microscope, what am I going to see? It's a very simple mnemonic. RPGN. आजकल तो बहुत famous है RRR, very famous. So that is our mnemonic. RPGN shows us the rupture and wrinkling of basement membrane. Rupture and wrinkling of the basement membrane is seen in RPGN. So first mug it up. RPGN shows us rupture and wrinkling of the basement membrane. Have a look at this. RRR dekhte hum. Can you see there is a basement membrane which is coiled like this, something like a snake coiled over here, and something like a snake coiled over here, right? So basically this is the area where the rupture happened. The rupture happened in this area, and the rest of the basement membrane has wrinkled. So there is a rupture and wrinkling of the basement membrane. So now, having said that, I've understood RPGN, I've understood crescent, I've understood RRR in electron microscope. Now I have three things: RPGN type 1, type 2, and type 3. Type 1 is the Goodpasture syndrome, and can you help me with the immunofluorescence pattern? Type 1 is going to show us a linear immunofluorescence. Type 2 has all the immune complex kind of things like SLE, HSP, and the immunofluorescence that you have over here is the granular immunofluorescence. whereas type 3 is posse-immune, means nothing, no electron microscope deposit, no immunofluorescence deposit, nothing is going to deposit over here, and in fact this happens to be the most common type of RPGN. So let's reassess. Like I told you, when they are talking about type 2, they can't talk about linear. Type 2 is going to show me granular immunofluorescence. Similarly here, type 1, not granular. Type 1 is going to show us linear immunofluorescence. Talking about type 3 showing deposits, not at all. The only correct statement over here was option 4. I think that is, yes, I hope that is clear with everyone and we can move forward. Okay. Easy question, mixing systemic and a little bit of general path. Yes, please let me know. 8-year-old boy presents with sore throat. No medication was taken. Okay, so as I notice, all of you are right. It's a classical case, isn't it? Firstly, I have a pediatric population given to me. Then I have a child who's come to me with sore throat. So I'll write down the chronology of events. First and foremost, this child has come up to us with sore throat. After sore throat, after 2 weeks, the child has come to us with cola color urine. Now, whenever cola color urine is mentioned, cola color is basically dark brown. They are trying to tell you that blood is coming out in the urine. They're trying to tell you that the urine sample is going to have hematuria. Okay, so obviously when you do an examination of this urine, you will see a field full of RBCs, obviously, because it is full of red blood cells. And also we saw mild proteinuria, because the disease that we are classically talking about over here is post-streptococcal glomerulonephritis. See, it is post-streptococcal. Streptococcus has always a feature called sore throat. So that is why the child had sore throat. And 2 weeks later, 2 weeks later, he had cola colored urine. So why this gap of 2 weeks in between? Because post-streptococcal glomerulonephritis is a type 3 hypersensitivity reaction. When I talk about type 3 hypersensitivity reaction, it is a fact that from the starting to the ending of type 3 hypersensitivity, it takes 10 to 14 days. That's the rule of type 3 hypersensitivity. It takes 10 to 14 days. That is why from the starting of the sore throat to the end result, that is cola color urine, 2 weeks time was there. Type 3 hypersensitivity, PSGN. And because PSGN is what? PSGN is a kind of a nephritic syndrome, and nephritic syndromes will obviously have blood in the urine. And what kind of proteinuria? Nephritic will have mild proteinuria, which was also there in this question. I think that part is done and we can easily move forward. Okay, so here we go with the next question. Which of the following, again organ switch, which of the following is true about yolk sac tumors? Which of the following is true about yolk sac tumors? Expression of SAL4 and AFP, Homer-Wright rosettes, low serum alpha-fetoprotein levels, common in postmenopausal women, and Cole-Exner bodies. Sometimes you don't know the answer to all, but you can rule out things and also come to the answer. That's the concept of MCQs, right? That's how you solve MCQs. Very good. Everyone's given me a right answer. That is option A. But I want to rule out all the others. Firstly, Cole-Exner bodies. Which tumor shows us Cole-Exner bodies? And that same tumor is also seen in postmenopausal women. So the answer to both these tumors is the same. Cole-Exner body, perfect. It is seen in granulosa cell tumor. Granulosa cell tumor is the granny tumor. That is how we always learn it. Granulosa cell tumor is the granny tumor. It will occur in postmenopausal women, and that shows us Cole-Exner bodies. Okay, next, low levels of alpha-fetoprotein are never ever for yolk sac tumors. I know for a fact that yolk sac tumors are a very rich source of alpha-fetoprotein. So this is obviously a wrong statement. First one, the second one, Homer-Wright rosettes. Do you see Homer-Wright rosettes anywhere in the ovary? Where all do we see Homer-Wright rosettes? Homer-Wright rosettes are seen in a total of 3 tumors in pathology. Very good. Homer-Wright rosettes, which brain tumor? Which brain tumor? Medulloblastoma. Brain tumor, medulloblastoma. Another tumor called neuroblastoma, and E for bone tumor, that is Ewing's sarcoma. It is not to do with ovaries, so this was a wrong statement. Repeating, Homer Wright rosettes, medulloblastoma, Ewing's sarcoma, neuroblastoma. Obviously, by ruling out, the only option that I'm left with is yolk sac tumor shows us SAL4 and alpha fetoprotein, which I know. Definitely, yolk sac tumor shows us alpha fetoprotein. But what is this SAL4? So, this means I have a lot of markers to do. Acha, tell me one thing, yolk sac tumor is which family of tumors? Surface epithelial tumor hai ya germ cell tumor hai? What family of tumors is it? Yolk sac tumor happens to be a germ cell tumor, right? I think everyone knows. Perfect. It is a germ cell tumor of the ovary. Means what all can come under it? Can I say, okay, dysgerminoma bhi yahi category hai, yolk sac tumor bhi ye category hai. So basically, I'm talking about germ cell tumors in general. And even for the testes, I'm talking about. For example, instead of dysgerminoma, in the testes, if we were talking about seminoma. So I'm talking about a family on the whole. And now you need to know, especially INI-CET students, what are the markers that you got to know for the germ cell tumors. And few days back I was revising this as well. I hope you all remember. Remember something called 1, 2, 3, 4, 5 that we did? So 1 से सबसे पहले 117, CD 117. 2 से क्या था? With 2 we had something called D240. In the last class when I was talking about vascular tumors, D240 I taught you. Where did I teach you guys? That time also I made you revise all of this. D240 was where? D240 is also a special marker for what? Blood vessels or lymphatic channels? Specifically for what? It is a very good marker for the lymphatic channels. याद आया ये वाला question last time करा था. I told you for the INI-CET students it's a must. Good. So now we are talking about the markers for germ cell tumors. So CD117, so 1, 2, D240, 3 say we had OCT3, 4. With 4 we had SAL4 and with 5 we had 5 alphabets, that is NaNOG. That is how we had done. 1 for CD117, 2 for D240, 3 for OCT3, 4, 4 for SAL4 and 5 for 5 alphabets, that was NaNOG. All of these are the new markers for germ cell tumors. So over here, since yolk sac tumor is a germ cell tumor, definitely SAL4 is a very good marker for it. Only one question is left. अब yolk sac में call exner bodies भी नहीं है, Homer Wright rosettes भी नहीं है. So what bodies are actually seen in yolk sac tumor, which they will actually give it to you in the exam? A very very famous picture. I'm sure everyone knows something known as glomeruloid body or Schiller duval body. Whenever we are talking about yolk sac tumor, either it's a glomeruloid body or a Schiller duval body. Let's make a photo of it or let's directly pick it up over here. Schiller duval body. How do I identify it? सबसे पहले in the center we have something called blood vessel. In the center you can see red blood cells, that's a blood vessel. Then you have one entire row of tumor cells. All these blue color, blue pink color cells, these are all the tumor cells. Then you have an entire white color space. This entire thing over here, this white color is known as a khali jaga. It has nothing in it. It is a total space. And finally, you have another line of blue color cells. That's going to be another line of tumor. So what is it? You'll say, ma'am, blood vessel, tumor, space, tumor. Repeating, let's draw it. See, blood vessel, I'll highlight it. Blood vessel, then tumor, then space, then tumor. Same way over here. Blood vessel, then tumor, then space, then tumor. That is a glomeruloid or a Schiller duval body. I hope everyone's got the point. One more thing I want you to pick up. Can you see these pink colored dots and balls that are made over here? Round globules kind of a thing. Please remember these are referred to as hyaline globules. They will never tell you as a picture. They will never tell you to pinpoint hyaline globules. No, how will the question come? Hyaline globules are seen in which ovarian tumor? Hyaline globules are seen in yolk sac tumor. Why? Because hyaline globules are nothing but made up of alpha-fetoprotein. And do I know that yolk sac tumor has very high levels of alpha-fetoprotein? So that is how they look like. They look like these pink color balls. They look like hyaline globules. That's a theoretical question that you guys can get in the exam. I hope that's okay with everyone. Yes. And coming to the last question of the day, coming back to what we studied a while ago. Last question of the day, then we wrap up. Regarding the pathogenesis of crescentic glomerulonephritis, what we just studied, which of the following is the first and the most crucial event leading to a crescent formation? Right now, I taught you about crescent, so one advanced knowledge for INICET as well. In fact, this was also a PYQ. I see A as one option, and some of you mentioned D. A and D में confusion है. So the first and the most crucial event is going to be endothelial cell injury. Not much that I can give you from, what can I say, concept point of view, but definitely as a starting event. Gradually everything will get affected. Gradually when a crescent will form, think logically crescent में क्या क्या था? What was the mnemonic for a crescent? You said ma'am the mnemonic for crescent was flap. So number one, it had fibrin. Fibrin कहाँ से आएगा? Fibrin will come from blood. L, leukocytes. Leukocytes कहाँ से आएंगे? White blood cells ना, they will come from blood. So majority of the things are coming from blood. So the first event that has happened actually is the endothelial cell injury that has happened. Endothelial cell injury has happened, and that is the primary event that results in the formation of that crescent. So like here they asked you, first and the most crucial event, endothelial cell injury expected in the upcoming INICET exam. That wraps up our session for today. One thing that I have not been able to include because of time constraint was Gleason scoring and pattern. But in the coming lesson with your other targets, I will be including Gleason. A little bit of purposely also I have done that because I know you guys had the targets ready with you and you've mugged up Gleason. But abhi ek do din mein bhool jayenge because with Gleason that always happens, right? You read, you forget, then you read again and then you forget. So I'd given it to you as a target, but I want you to forget it for 2-3 days, and then I'll give you the questions and I want you to attempt it then, because in the exam you will be in your remote memory. You will not be working with your current memory, your short term memory. You will be working more with your long term memory, right? So I will be coming up with Gleason, but thoda sa bhool jao, so that we know by the next time how much could you actually retain, and if you want to revise and come in the next class, nothing like it. Okay. Right. I know. So I think I was thinking on the right track. सबको पता है and everyone was waiting कि Gleason का question आएगा. But वो आएगा but after 2-3 days. So let's see how many of you remember it after 2-3 days. And I know you guys will. Abhi it's just that scare will also go. You will remember it. I'm very certain on it. So don't worry. Okay, fine. So thank you for joining in. I'll be meeting you very shortly in 15 minutes at 4 o'clock, FMG crash course. And for students who joined us late, that is the plan for tomorrow. Tomorrow's classes, 7:30, we have a kickstart morning on virology. 11 a.m., the same 5 questions that we are doing. And 4 o'clock, there's an FMG crash course that is going on. That's the plan for tomorrow. Okay. ठीक है, I'll post the targets today itself. Point noted. Done. Okay, thank you guys for joining in, and all the students who are joining me in 15 minutes on the app. Let's meet again after a short break, 4 o'clock for the FMG crash.